finish up what we're going to do with the nervous system. And then today in lab, we have a lot of lab time today that we're going to actually, we're going to have, I hope y'all have some fun. We're going to be looking at real brains. I'm going to be giving you the actual areas, a word bank for the brain, for the eye, and for the ear. So I'm going to give you the word bank. And today we've got plastic models of brains. We've got real brains to look at. And then we're going to together dissect an eye. So, you know, you can either get in groups of 2 or you can have your own eye if you want to dissect. So we're going to be dissecting an eye while we're making sure that we're looking at those structures that we need to be able to label on the eye and making sure we know where every one of those structures are as we're dissecting. Also, I will do a little quick demonstration of the reflexes. So you all can, if you got a buddy, you can do reflexes on each other. So we just got a few things we can do in lab today, right? But mostly we're just going to be together. So after the actual dissection of the eye that we kind of do as a group, it's just going to be casual, but it would be the time for you, if you think there's any holes in your notes, if you think there's anything one of your peers could help you with, or me, it would be the time for you to do it, because today is our last day really together for that time. All right? Fair? All right. And then Thursday is just testing. Okay. All right. So let's go ahead and get this last information covered. I want to cover, you know, the things I talk about are things that I think are the main things that you're going to need to know. Did we finish this? No. We did the cranial nerves. Yeah. Okay. So we stopped at cranial nerves, and actually on chapter 15, there's really nothing that's not redundant. So there's things that are repeat. Do we know that the difference between, when we talk about the autonomic nervous system, things you don't have to think about, things that are being taken care of for you? Did we talk about the sympathetic versus the parasympathetic systems? Yeah. And did I give you a definition for reflexes and what reflexes are? Did I? Yeah, I did. I gave you, what's the definition for a reflex? Yeah, would you say, Ashley? Yes, well, it occurs, it's a stereotypical response, which means that this is what's going to happen as an automatic response. And it should be at just the right level. It shouldn't be over-exaggerated, and certainly shouldn't be slow, right? And what did we say the function of reflexes are? To protect us. They're to protect us. And that's exactly right. So again, in this chapter, it's a lot of repeat information. But again, this is the kind of thing that people who are wanting to ask questions about how, why, what's the relationship, metacognition, this idea that you're thinking about how you're thinking. You're thinking about how am I learning this? What do I need to do? How, and I get a fact, but why is this a fact? What led us to this? What did this? What's a relationship I know to this? When you're doing all of that, you're beginning to own it. All right? So this chapter, even though chapter 15 has a lot of repeat stuff, it wouldn't be a bad idea to read it, would it? And so I just sort of show you that there's a lot of redundancy. There's some redundancy in here, but that's not a bad thing to have the redundancy. We call the sympathetic system our what system? The sympathetic. And we called our parasympathetic system the what? We sort of called our parasympathetic system our housekeeping system. It's going to be what's, making sure that our cells are regenerating, getting what they need, our immune system's strong, our nutrition's happening. So just, we can eat something, but it doesn't necessarily mean it's going to be absorbed and or, used. Are you finished? You are. So thank you, Justin. So absolutely, that's that system. And there's more information in this chapter showing how the system is innervated. But we're just, if I don't talk about it, is it necessary for you to know it? Did we talk about the idea that some neurotransmitters excite and some of them actually inhibit? Did we talk about the idea that some neurotransmitters do both? depending on which target site. So this is all, again, kind of reinforced in this chapter. I'm trying to see if there's anything new. Not really. In this chapter, that's why I said there's really nothing in this chapter. But would it make sense to you if I told you that a drug, or you looked up a drug on your patient and that drug said that it was a sympathomimicker, that it would mimic what the sympathetic nervous system would do? So what would you expect all the vital signs in your patients to be doing, on that patient to be doing? If they're on a drug that's mimicking the sympathetic nervous system, what are their vital signs doing? They're going up. So if you've got a patient who's already got vital signs that are a little bit, blood pressure too high, heart rate too high, respirations too fast, are you going to give them a drug that's mimicking the sympathetic nervous system? Or if they're on one, are you going to say, make a note of it and say, wait a minute, I need to ask if this patient should be on this? Right. And if you've got something that is a lytic drug, it means it's going to split it. So think about that. So when you think about the parasympathetic, well, you can read it, lytic drugs, if it says that when you're looking at the drug, you know that it's actually going to be doing the opposite of what that would do, right? So that's just terminology. How about caffeine? Wouldn't we say that we know caffeine does? It's a stimulant, isn't it? It's a stimulant, and I think in your textbook you actually have, in your textbook you have a picture of what caffeine looks like, just the molecular formula of caffeine, but it is a stimulant. And then we know different drugs are based on what they're doing to the nervous system. So some of them stimulate, some of them depress, right? And they have different functions and so of the nervous to the nervous system. But anyway, so it's chapter 15, and there really wasn't anything new, was there? Was there? No, there was nothing new. But not a bad thing to revisit it if you have all the time in the world, which I know you don't. But anyway, later. Do we stop our study of Anatomy and Physiology 1 once Thursday's over? Do we stop our study, or do you all continue to read about this? Do you continue to look at those deeper insights, making sure that they just really make sense to you, and those disorders, and going back through, yeah, and the anatomy as well? So you don't stop after Thursday. Please don't. So anyway, let's go ahead and finish up with the special senses today. And what we're going to be looking at is going to be mostly, the basic things: smell, taste, hearing, and sight. So, FYI, did we say FYI? Meaning, I don't question this, but did we say neurons? Would it even make sense that if they all look exactly alike? Or do we understand they're going to look different? Their anatomy is going to be different based on their function. So we get that. We get that there's different ones. And, we get that they're going to be named based on what they do. Does it make sense to you that chemoreceptors are the receptors that are going to be stimulated, action potentials generated when chemicals are changed in the body? So chemoreceptors are going to pick up things like oxygen levels, CO2 levels, pH levels. You all had told me that we remain in homeostasis by negative feedback, didn't you? And you said it's the nervous system that sets the set points and detects when things get high or low, and is then going to send a signal to keep you in the nervous system. Lord have mercy. Is that me, Rodney? Oh, Lord have mercy. Okay. Is anybody in 28? Rodney? Hold on just a second. But, gosh, I don't want you to lift it. Right now, you have to look at all that stuff. Are you sure? All right, guys. So we said that in negative feedback, it's going to send a signal and keep you back in homeostasis. Thermoreceptors, what do you think they get stimulated by? The temperature changes. Nociceptors, no. Make sure this makes sense to you, right? Chemical changes. Thermal is temperature. Nociception means pain. You would want to know that. Nociceptors are pain receptors. Pain, a good thing or a bad thing? It's a good thing. It is a good thing. The bad thing happens when you take like opiates that aren't natural or part of your own, and then your postsynaptic cells start not responding to them, and your presynaptic cells won't send your own endorphins. What are your own endorphins? What do endorphins do? They mask pain, and they're your natural pain relievers. So now you're not producing any natural pain relievers because you're taking external opiates. And guess what? You feel pain. You feel pain because you don't have anything natural going for you anymore. And so it's incredibly addictive, isn't it? And really bad. So anyway, mechanoreceptors is pressure, mechanical pressure, and photoreceptors, photo means light. So these are special neurons that are going to be innervated by light. Where do you think we find these? Light. In your eyes, yes. In your eyes. What'd you say?
Oh, there's electric.
The melanocytes definitely can, but actually it's the eyes. So are these photoreceptors. So great. All right. So we kind of get that. And I don't really care that, some are encapsulated and some aren't. I don't really care about that. But we said we understand pain is a good thing. Can we use pain when a person's talking to us about pain as far as one of their symptoms go? What's the difference between the sign and the symptom?
Symptom is what they're telling you. A sign is what you can see.
A sign you can measure. You can see a sign, like a road sign. You can see it, you can measure it. But a symptom is exactly what you said, Nicole, is what they're telling you. Now, you'll get this crazy thing on like tests sometimes about pain being a sign because you'll ask them to measure it on a scale of 1 to 10. That's ridiculous. Because, people say, oh, it's at a 10. I see it all the time. People say, it's a 10. No. If it's at a 10, they weren't listening to your question, much less answering you. Do you know what I mean? They couldn't hear your question. Right. So they can't talk to you. So that's a really 10. So it's just, it's not really measurable. And everybody has a different interpretation. Y'all hear about high thresholds for pain and low thresholds for pain. You've heard of that, haven't you? And that's just the person's own individual response to their own endorphins. Really. So, but I want you to know about this phenomenon called referred pain. You already know about it. Y'all know if somebody, especially if they're in a certain age or look and a certain overall health appearance, if they're all of a sudden having left arm pain, if they're older and maybe a little overweight, having left arm pain and left hand pain, what are y'all worried about? You're worried about heart attack, aren't you? Between the shoulder blades, the back of the neck, gallbladder. So you can have all kinds of referred pain. These are some typical ones that we know about that can happen. So great. Now I want you to bear with me for a second. Okay, yeah. Oh, so I want to think about the first taste. You guys, I want you to know that if you looked at a histology slide of a slice, just 1 to 2 cell layers thick on the tongue, they're going to be these specialized little areas, these cells called taste buds, and you know that, on the surface of your tongue. But what we know about the tongue, and this is a superficial view, looking at the tongue, so the tip of the tongue, the base of the tongue, like the bone. Okay, so we're looking at the tongue. When we think about these taste buds, they're all dispersed all kind of throughout. And there's 5 types, and you would want to know them. You would want to know these 5 special kinds of taste. You really only have 5 taste sensations. They are sweet, salty, sour, bitter, and one that's called, and I don't even know for sure how to pronounce this, it's kind of new, umami. Umami? Okay. Umami. It's an L and an M. I don't know how to say it. What is it? Unami. Oh, unami. Umami. It's an M, though.
I know, but I think that's how it's.
Really? I don't even know. Look, so that's what it is. So it's kind of new. Like I learned there were 4 tastes, but this is a kind of a new one. And the way they describe this one, because we all can think of what sweet, salty, and bitter and sour are, but the way they describe this one is a meaty or beef bouillon-y So when you think about that, I think it's salty. That's what they taste like to me. Sometimes they say MSG, but I don't know. But there's 5 distinct ones, and these are the 5. Now, when we think about them, where they are, they're all kind of dispersed, but they are usually congregated by their modality. So this is the tip of your tongue is sweet. It's predominantly with the sweet, sensations. This is why I say you lick lollipops and ice cream cones, because you get the best from it. Okay, so I don't know. But the sides are salty. The sides are salty and bitter and sour. Who knows where the other one is, but bitter and sour at the back. And you can think of that, because when you have something bitter or sour, what's your response? Yeah, it's almost like it's generated from back there, isn't it? Y'all know it is, right? So it's because predominantly they're back there, but they are also kind of spread throughout. Here's what I want you to know the 5, and I want you to know that before you can taste anything, you have to have enough saliva. So is it going to be a problem if you have a dry mouth? There are a lot of reasons dry mouth is a problem. The health of your mouth, the tissues of the gums, the health of your teeth are all relying on you having enough saliva. You produce 1.5 liters of spit a day. It's a wonder we're not just little drooly messes, right? But we produce that much a day. And certainly do we produce more if we're thinking about putting something in our mouth. So when you're thinking about eating something, you start to what? You certainly do. That makes really good sense. I want you all to know about an autoimmune disease. An autoimmune disease. And this autoimmune disease is called Sjogren's. It's Swedish, so it's Sjogren'. It was a physician who first identified this, but it's pronounced show, like a Broadway show, and grin, like you grin. But anyway, Sjogren's, it's a fairly common autoimmune disease. Do we know what autoimmune diseases are? I know I do this to death, but it's important that you understand that autoimmune diseases, can you catch them? No. And do we always know what causes them? No. Do we think there's a familial component? Yes, we do, because we think those things are having some sort of genetic component, but not always, so we just don't know. We do know mostly they are women, mostly between 20 and 40s, maybe the onset. So these are kind of common things. Sjogren's is an autoimmune disease where your immune system starts attacking your salivary glands and your lacrimal glands. What are lacrimal glands? Tears, producing tears. So is this problem dry eyes and dry mouth? Would that be a problem? You all know that if you have a cold and you take decongestants, what happens to you? Right? And it's not just because you have a cold and you can't smell, but you're also drying yourself out if you're taking those over-the-counter meds. And do you have any real taste? What happens to your appetite? It goes down. So we need these taste buds working. We only have 5 sensations of taste. And some of you are thinking, well, wait a minute, what happened to lemon? That's so good, lemon, or orange, or whatever. That's not taste, that's smell. So, and that your smell and your taste buds working together give you those sensations. But you really only have 5 taste buds that are doing this. If you were to lose your sense of smell, you wouldn't have those other things. So, you have to, for something to be tasted, it has to be, they call it emulsified. Emulsified means it has to be wet, okay? Wet enough. All right, now, I also want you to know about smell. And we already know about the olfactory nerve, don't we? The olfactory pair of cranial nerves, you'll see it on the human brain today. This human brain's little olfactory nerves are kind of shriveled a little bit, but you'll see they're intact. And you'll see the right and left one. And this projection back to actually, it's part of the frontal and the temporal lobe of the brain. But people, and this got cut off, but some people have such a heightened sense of smell that they can actually distinguish between like 10,000 plus different smells. I don't know how they got tested for that long, but anyway, they're very heightened sense of smell. How many of you would say you've had heightened senses of smell before, and you go through periods of that? Some women are really sensitive to their hormone changes throughout the month, and at certain times of the month with their hormone cycles, they'll become really sensitive to smells more than others. But
Does that explain pregnancy too?
yes, it absolutely can explain that. And would it make sense to you that when you're pregnant, should anything that can help your appetite be encouraged? It really can. So when people, and also there are things they're like THC can, people make jokes of people who are getting high that they have the munchies. It's not because they're hungry. Guess what gets heightened? Yes, that's why. So that's directly linked to our appetite centers. This is also why, as we age and people have lost their sense of smell and taste, what can happen to their appetite as they age? It goes down. And it's so subtle that they don't really realize that because their appetite's gone down, they stop, eating or actively seeking out foods of certain things. They've sort of lost their appetite, so they're eating less, they're eating whatever. Can that directly affect their health? Yeah, of course. So again, for smell, I want you all to see when you look at this mid-sagittal section here, obviously this is an Aries. So as odors move through, this is the only cranial nerve. These are the only nerves, actually. Excuse me, not just cranial, but only nerves that are open to the external environment. People should be careful what they put up their nose. These are the only nerves that are open. So when you say that, could actually something bad travel along this olfactory nerve to the brain? Yes, it could. So yeah, definitely. And you need your nose to be wet inside, because you can't smell something unless you have enough moisture in your nose. Have you ever noticed that you can breathe out of one side of your nose better than the other at any given time? Now, I'm not talking, those of you who have deviated septums, you might not ever be able to breathe out one side of your nose because your septum's deviated. But those of us who don't have deviated septums, have you ever noticed that you can, at any given time, one side of your nose you can breathe out of better than the other? And the reason is that you have erectile tissue. Yes, I said that. Erectile tissue in your nose. You have it in other places too, but you have it in your nose. And you have it here because every 20, 30 minutes or so, this tissue engorges with blood and gets swollen. But that blood's bringing warmth, it's bringing moisture, and it's keeping your nose wet on that side. And then the other side will engorge with blood. So this is a coordinated thing you don't have to think about. To keep your nose wet, keep your nose able to be able to detect odors. And this is protective. This is also something for appetite. This is a good thing, right? Any questions for me about that?
It's open to external what?
The external environment. External environment. So again, this is why can we deliver sometimes medications through the nose? Can we? Yes, we can. And sometimes people do drugs through the nose. The problem comes in when that olfactory, and the problem can come in when that olfactory nose meets back there near that. You remember me talking about the third ventricle, the ventricles of the brain? You remember the ventricles are where CSF irrigates the brain? And the third ventricle, between the third and fourth, there's this little window. And that little window is an area where the central nervous system is actually detecting what's going on in the bloodstream. And those chemoreceptors are keeping everything balanced. And it's right behind this olfactory. So when you put something up your nose and it hits that area, it can hit that autonomic nervous system in such a way that it can have really adverse effects to your autonomic nervous system. So like the heart can just go crazy. So have you ever heard of somebody doing cocaine in the heart? They call it exploding. The heart doesn't really explode, but kind of it does. You get what I mean? Because it gets that signal. And it was a fluke, it was a whatever, but it wasn't really a fluke, because what did they do? They had this direct access really close to that third ventricle, between that third and fourth ventricle, to that little window, right? So it can happen. Anyway, it's actually kind of amazing it doesn't happen more. Look, can smell take us to a memory really quickly?
Yes.
Yes, I think we talked about it. So these olfactory nerves, as you see them, and they go back here to the amygdala and hippocampus, and a smell can take you to a memory much quicker than something that you're looking at as far as a vision. And it's because those two areas of the brain are side by side. A memory and an emotion. Okay, so to taste and to smell, it has to be wet, right? Has to be wet. 5 taste sensations throughout the tongue. We understand there's several cranial nerves that innervate the tongue that control things from not just movement of the tongue, but also blood pressure we talked about. So we did that. And the that's just a review. And then the olfactory is for smell. All right, so sound. As I said, I am going to give you all a list of the structures that you would have to identify with sound. Does everybody sort of know the perspective of this picture? Okay, so we know that we've done a coronal section and we removed the front, right? So we're taking a look here and we're seeing bones and all this stuff and whatever the external here. So sound. I want you to know when we think about sound, right? When we think about sound, what that really is are these compressed molecules in the air colliding with each other in a wave type of pattern from where the sound was generated from, and they're going to move in a way just like a wave's hitting the shore, and they're going to be caught. These compressed molecules are going to be caught by this shell called the auricle, which you call your ear, right? Your outer ear, this auricle, which is like a shell that is going to tunnel these wavelengths into this external canal, auditory canal. Now, I want everybody just kind of look at the thing and see if it doesn't make sense to you at this point. So what it really means is when you hear something is that these molecules got compressed and they're sending forward, they're moving forward, or just like dropping a rock into a thing of water. You see what happens, right? So these are moving here. And when it hits this very flexible little tympanic membrane, eardrum, this membrane is going to do what? Vibrate. It's going to vibrate. Every time one of them hits, it'll vibrate. And it'll move back, and then the next one hits, and the next one hits, and the next one hits. I'm going to show this to you in a mechanical version in a minute, because I think it actually makes a little bit more sense mechanically. But I wanted to show you this anatomically first. So this membrane is vibrating every time the compressed molecules get to it. It's vibrating. There's a little bone called the malleus that is connecting with it, articulating with it. So this is moving every time it vibrates. This is moving. But the malleus is connected to the incus. So when it moves, the incus is being moved, and then the incus is pressing on the stapes. So these 3 little bones in this middle area of the brain are going to be affected by this vibrating, right? Because they actually have little joints between, and they're going to be affected by that. This middle area of the ear, did I say brain? I meant ear. This middle area of the ear is actually referred to, when you have an infection, is otitis media. Have y'all heard of that? Otitis media? Because that means inflammation of this little middle part where the bones are. This little middle part, it's so important that these bones be able to move the way they're supposed to move, that this little part is filled with air. It needs to be filled with air. It's so important that it's got air and not fluid, that it has a drain tube. You all call this drain tube the eustachian tube. This drain tube is draining to the back of the nasopharynx, which is the back of your throat. So obviously you have a right one and you have a left one, and this is why you can hold your nose and put pressure on it. What happens? What do you feel like happens? Your ears pop, because you understand there is a direct connection from your nasopharynx to your waist. And if this were filled with fluid and this membrane was being pressed out, could it vibrate? No. So it has to be filled with what? Air. If there's any fluid in there, is that going to be a problem?
Yes.
Yes, we get that. All right, so far we're kind of looking at the mechanics of this, aren't we? So we get that the membrane vibrates, the malleus is affected, the incus is affected, and the stapes is pushing against this little window here. And when it pushes against that, you all see this little area that looks like a snail? It does look like a snail, doesn't it? This little area is the inner ear. And we had already mentioned this area before when we talked about cranial nerves. We said that this is the vestibular complex or body or apparatus. You'll hear it referred to as all the vestibular. It has these semicircular ducts. Why do you think they're called that? The semicircular, because they're semicircles. That's why they're called it. And they're filled with fluid. They are filled with fluid. So this is the vestibular part, and this is the cochlea. The body of the snail is called the cochlea or cochlear region of the inner ear. And when this stapes is pressing here, there's fluid here that's going to be sent, just like you moving in a bathtub. What happens to the water in the bathtub? It starts to form these waves, right? So that's what's happening when the stapes does this. And in the cochlear area of the inner ear is where sound is generated. And this is the cochlear nerve that meets up with the vestibular. Now we're going to talk about this again in a second. Hold on to that whole idea. And use this if this helps you. Might not help you, but use it if it does. This means, this is kind of beautiful. We say compressed molecules, right? Moving away, just like dropping a stone and of water and a palm, moving away, and as they get caught by the auricle, they're going to be sent to that auditory canal, right? And they're going to hit up against the what? Tympanic membrane, which is what you call what? And as that membrane moves, what will move with it? Malleus. That's going to affect the incus, which is going to, it's like the hip bones connected to the whatever. That's going to also affect the what? And the stapes is going to press at this little window. And now this is the inner ear. And we said as the stapes presses, is it going to cause an action potential to be generated in this cochlear region? And as that action potential is generated on that cochlear nerve, that gets interpreted as sound in our temporal lobe. Let me ask you something again. I know I've already talked about it. Do you actually hear with your ears? Or does the action potential that gets generated on this cochlear nerve send a signal to your temporal lobe of your brain and you interpret it as sound? Where do you really hear? Exactly. The temporal lobe of your brain. Just like sight is really happening where? In the occipital lobe of your brain. These are the receptors though, and do these all need to be working? Yes. Does everybody see what the correlation of this is with the actual structures? Use this. Make this make reasonable sense to you when you are learning. Do you see why that middle ear had better be filled with air? Because if it's filled with liquid, this membrane is not going to be able to do what? It's not going to be able to vibrate. And sound, not that it's not important when we're old, but when we're little, sound, we mimic sounds, don't we? We mimic the sounds we hear. So have y'all ever known anybody that couldn't hear very well? They speak very differently, don't they? But they're mimicking what they hear, because we do that. We mimic what we hear, and we mimic those sounds. Okay, so
I have a question.
Yes.
When they put tubes in the ears for drainage, where does that go, and what exactly is it like?
So a merinotomy is going to be where you put tubes in the ears and the ear and the tympanic membrane. So And I'm just calling it that because you need to know that that is what they know the eardrum is. So when they do this, they take a tiny little hollow tube, and they puncture through this membrane, and it's got a little clip on the back side that holds it. They spring load it, and it clips it into place, and they're done. So when they put somebody under to put tubes in the ears, it's for like 2 seconds. It's just long enough to immobilize them so that they don't move while they're doing that procedure. That's as long as they're under. But that's the risk of any type of surgery, isn't it? Is the anesthesia. And that's a serious risk because what is that affecting? The nervous system. Exactly. So that's the serious thing. But anyway, so what they're doing is they're putting a little hollow tube here so that fluid is not just draining this way, but it can drain which way too?
Out the ears.
Exactly. So that's what they're doing. They're hoping that it stays for 6 months. Some of them don't stay past the time it takes you to get to the parking lot. Did y'all know that?
Mm-hmm.
Some of those tubes are out before they know this, that they've probably fallen out before the kids get to the parking lots. But they hope for 6 months. And then some of them don't fall out. So what are they going to have to do? And actually, when they punch through, is that going to scar that membrane then? Yeah, but they weigh that. They weigh the bad, which is the scarring it's going to cause, with what's been happening. And repeated infections, can they scar the eardrum as well? Yes.
Like I had to get tubes 3 times. Like I got
Wow.
a ear tie was 2.5.
Yeah.
Because they called it congestional deafness because I was just so like congested.
Always congested.
But they also took out my adenoid.
Yes. Yeah. And you know, I actually, and you probably got much better. As soon as they did.
I can hear it. Like my mom, like as I was having she went in every week for 2 years.
But as soon as they took the adenoids,
Mhm.
your adenoids are really tonsils. They're pharyngeal tonsils that are on the back of your nasopharynx. Where did I just say your ears drain to? Middle ears drain to? The nasopharynx. If your adenoids are these big honker things, on the back of your throat, if your adenoids are big, is it preventing the draining of the middle ear?
So they took those out first, and then my doctor refused to do it, and then my mom kind of was just like, "I'll go to a different doctor," and then I finally got the tubes.
Yeah. So let me just tell you, also babies have baby heads. So what, and I'm not meaning that as a joke, it's just true. Their heads, their eustachian tubes don't have a nice slant on them. Because their heads are like little blocks. So their eustachian tubes, instead of having a nice slant or gravity, they actually don't have that slant. So what happened, that's why people outgrow middle ear infections sometimes, is because really their head becomes, by 8 or 9 years old of age, gets a better slant on those eustachian tubes. Middle ear infections are almost all caused from allergies. The next most common cause are viruses, which babies have a lot of because they haven't been exposed for that, so they're staying congested. Also, sucking. What's our instinct we're born with? It's really the only, mostly the instinct we have is to do what? Suck. And so we're sucking, but when we suck, what is that doing to the pressure of the eustachian tube? Forcing things back. This is why you never put a child, especially a child who has some congested things, you never put them down with a pacifier. They should never have a pacifier or let them suck their thumbs. I know that's mean. So, but you also, you don't put them down with a bottle, do you? And when you feed them, when they're still sucking to feed them, you make sure that you're in a position that is not where they would be pushing that fluid back into that middle ear, because that's what's happening. And all of that's genetic.
Because
Yeah.
it runs in my family.
Yes.
There's a few of us that we had to get tubes a couple of times because we were just having terrible.
Because you had a lot of fluid that
Yeah.
wasn't draining. And that is absolutely genetic because it's anatomical. It really is anatomical. So, but there's some things we can do to try for those people who are going to be really susceptible, like not having pacifiers and or thumb sucking. But that's really hard, isn't it? How many of you did pacifiers? Or how many of you knew, how many of you had a baby that you just couldn't, it broke your heart to take the pacifier away? Okay, so what, well, yeah, so far, but if they're having recurring infections, then that's a problem because they can't hear. And is that going to affect their language skills?
Oh,
Yeah, and so, and what we know about the plasticity of the brain is that it continues throughout your life. That's a good thing. But is it amazing when they're young? And is it amazing for language when you're young? And this is why language is, that's the time to grow vocabulary. Can kids learn language from flat screens? We know it now. They cannot. So when people are putting kids in front of screens thinking, oh, this is good for them, it's an educational show. Not. I mean, there's enough data in there. There's enough scientific data in there to understand that. There's actually 0 screen time for a child before 5. 0. So language is learned from hearing, and then mocking those sounds and seeing how, and actually having them person. So does that help you to know who asked? Thank you. Okay. So yeah, that's what tubes are. How many of you know kids, or maybe happened to you, that you had a ruptured eardrum? And it was was it you or your tongue? So it's incredibly painful, right? And then as soon as it ruptures though, it's like, but when that's happening, that's scarring too. And so if they know that somebody's keeping those, it's better maybe just go and have a controlled scar where the tube is. And I don't know if it used to be that you'd have to have so many in a window of time. So a child would have to have so many infections in a certain window of time before they would do the tubes. But I don't know what the protocol is now. And it's probably different between each ENT, specialist, because you can probably find somebody to do whatever. All right, so this anatomy kind of makes sense to you, does it? Does it make sense to you that in this outer ear, this external part of the canal, that there's a lot of nociceptors? What are nociceptors? Pain receptors. Why would it be that way?
it's exposed to outside.
From? The pain receptors here. How many of you had swimmer's ear? Was it hurt? Did it hurt? Did it hurt a lot? So somebody tugged on your ear a little bit and it just was like, it hurt so bad. I've never had it, but that's what I hear and I've seen that these patients will do. So swimmer's ear, you don't have to be a swimmer to have swimmer's ear. It's just that you get water in this canal, and you get water from bathing and from showers and swimming, but from those other things too. And this canal is usually waterproofed by what? Earwax, to keep water out. Because water is not sterile. It's not supposed to be. We don't live in a sterile world. We live in a microbial world as guests. So water's not sterile, but this is keeping it waterproofed if you have not tons, but enough earwax, right? It also is filled with pain receptors because you want to know if something is going toward your what? And you want to stop. You want to stop. So it's protective to have pain receptors here because it'll stop you from putting, what's the saying? Don't put anything in your ear that's smaller than your what? Your elbow. Have y'all ever heard that? Which obviously is crazy. But you're not supposed to put anything here. Are you supposed to do Q-tips? Not supposed to do that. The earwax is healthy. Supposed to have. But some people get abnormal types of earwax and it can really block the canal. I've seen, and I remember one really vividly, one gentleman coming in and they were sure he was having a stroke. Could not walk, could not respond. It was just absolutely like a stroke victim, and an elderly gentleman. And we with examination realized he had his ear, one side of his, it was just one side, was completely blocked with earwax. I mean, completely. It was amazing to me. So in the ER, we're doing these ear baths. Has anybody ever seen earwax removed from, you have helped with it? It's amazing how much earwax can get packed in an ear. I had no idea. I was like thinking, this cannot be happening. So not just picking the earwax out, but when we did those warm saline washes, we're catching it in the emesis basin, right? So in this little basin, and I'm thinking, okay, that's got to be all. That's got to be all that's coming. But it was hitting the emesis basin like gravel dropping into it. Gravel. It ended up being almost a cup of gravel-looking stuff, earwax, hardened earwax. It was so packed in that it was pressing against even his inner ear. So he was dizzy, he could not speak, he could not hear, and he could not walk, whatever. As soon as that was done, within 30 minutes or so, he walked out. So that was happy. Could have been worse if he had a stroke. So anyway, this is supposed to be working like it's supposed to. And this wax keeps things out like bugs, because bugs do crawl in your ears at night. You might not think of it, but they do crawl in your ears at night. These are ceruminous glands. Do y'all remember that? Make sure you do. Ceruminous glands secrete earwax, don't they? And is earwax a good thing? Yeah. So there's, so great. And lots of nociceptors. What's the middle ear supposed to be filled with? Air. And it's so important that it's got a drain tube called it's called the eustachian tube. Also, this is called the auditory tube, but no eustachian tube too, because we'll hear about that. And where is this eustachian tube drain to? You would want to know that. The nasopharynx. This part of your throat that's, when you say Andrea, say and say and I'm looking at her looking at her throat, but I can't see her nasopharynx. That's a little bit higher, the back part. Lower is the laryngopharynx. What I'm looking at is the oropharynx, right? But that just means throat. So this is draining to the back of the nose. This is why when somebody has conjunctivitis, which is, I haven't gotten that yet, but it's inflammation of the membrane lining the eye, and this drains into the nose, and the nose drains into the what? Nasopharynx, and the nasopharynx has access to the where? Somebody has an eye infection, you best check their what? Ears. And yeah, so that makes sense to you? Okay, so check the ears if that's the case, if they have conjunctivitis, inflammation of the lining of the eye. So do you have any questions for me about this? I want to just show you some basics. Are you going to be asked about anything I didn't talk about? What's the most common cause of otitis media? Allergies. What's the next? Viral. What's the rarest? Bacterial. What do parents want when their kids have otitis media? Do they work? No. Sometimes they're going to give them to them prophylactically. What does that mean? Just to prevent. They got such a bad case of otitis media that you're afraid that later what might happen? A bacterial infection might follow it. So sometimes they're given prophylactically, but thank goodness pediatricians now are not doing that as much anymore. Parents should not be demanded drugs. What you say?
What about eardrops for ear infection?
So ear drops can happen for ear. You can do antimicrobials, which is going to be against that bacteria that we think of that causes swimmer's ear. But you can also do like eardrops with pain. So sometimes that's necessary too. People are.
Because my daughter had college where she has emergency chronic ear infection, and she's had numerous too. And they gave her 2 types of ear drops. One she said for her, and one she liked.
Yeah, the antimicrobial, the one that was hurting, was the antibiotic that they're given for the external otitis. Swimmer's ear is caused by a bacteria known as Pseudomonas aeruginosa. Have I given you all that organism yet?
No.
Pseudomonas aeruginosa is causes external Pseudomonas. That's a P. That's a P right there. Pseudomonas. I can't write over this because it doesn't do. Can I write it over here? Mm-hmm. So, Pseudomonas is the genus name. The species name is aeruginosa. This organism is in all of our water. It's in our homes and our water lines, especially in the warm and the hot lines, because it likes hot. So if you've ever gotten in a hot tub and you saw that fluorescent sheen on the top of the hot tub, is that back there? Yep. So it's normal. It's everywhere. It's in our water. But it can cause otitis media. It causes external otitis. It is almost the exclusive cause of it. And to treat it, it's difficult to treat, Ashley. And so the drugs, the topical drugs, are big time drugs. They wouldn't be able to give those drugs systemically, orally. But when that's dropped on the skin, you know, it's sometimes patients say it hurts.
So my boyfriend actually has an ear infection, and he went to the doctor and they gave him ear drops and they gave him an antibiotic. But if the antibiotic doesn't work, why do they give it?
Well, I didn't say they don't always work. I'm just telling you that most of the time it is. And it depends on where the ear infection is. Is it external or media? Is it the middle ear or the outer ear?
They didn't specify.
Yeah,
They
so
just looked
so
at
people
the
want to
ear
know.
and the chin.
And sometimes there's like how many of you work with docs? Doctors. Okay, so docs. I mean, so you'll work with doctors who they don't mind writing scripts. They'll write scripts to get rid of people. How many of you work with them? Yeah, because it's a lot easier to write a script and talk to someone and try to explain to them what's going on and what you'd like to do for them to do behavior or whatever. But sometimes the drugs are needed. For this one, the antibiotics are needed for external. Because what did I just tell you? This is cholestatic, a bacteria. So yes, you do need the drug for that, but it's usually drops, not oral antibiotics. But if every individual's different, so if he's got something that would set him up to make him more susceptible to maybe this doing something else, then you would maybe give a prophylactic antibiotic. So let me explain something to you all. Please listen to what don't misquote me on things, okay? Saying never give an antibiotic. I didn't say that, did I? And here's what I did not say that, so please don't misquote me. That's what I'm saying. Don't just memorize something, because then you didn't ask why, how, and you didn't think it through, you didn't reason through. So, like for example, I will tell you all that most pneumonias are viral pneumonias. Almost all of them are viral pneumonias. But you want to give an antibiotic. Why? I just told you that antibiotics it's not bacterial. Antibiotics, when you give them, suppresses a person's immune system. It's going to suppress their immune system. It's going to make it a little bit harder for them to fight what they really have. But you still got to give it to them. Why?
Because your immune system is failing if you have pneumonia anyways.
And what's going to happen if you get a bacterial pneumonia on top of a viral pneumonia? You have about a 50-50 chance of dying. So they give the antibiotic as a prophylactic antibiotic. And sometimes that's in other cases too. You get what I'm saying? Every individual is different and their things different. What makes you crazy are the people who are over prescribing and are doing, because does that harm not just the person, but does that create superbugs that we have and out there now, and then the whole community is affected? And you get what I mean? So in a perfect world, and I know I'm sitting here kind of in a little glass house, but in a perfect world, patients would be seen head to toe, not just for their symptom. In a perfect world, we would have time to really investigate. In a perfect world, we wouldn't be prescribing so much. We wouldn't, but it's not a perfect world. So sometimes people really got to do. Okay, did I muddy the water, or did y'all feel like that makes sense? Right. Okay, all right. Okay, so just these pictures. I like pictures. How many of you like pictures? I like pictures. So when we think about the stapes, this is an electron micrograph where we can really see incredible detail. When we think about these cochlea, now they're not really hairs. They're the nerve endings, okay? So when we think about this cochlea as a dissection of this cochlea, the organ of corti is actually where this action potential gets generated. So look at this dissection here, and then let's break it down and look even at these hair-like they should put hair-like nerve endings. So as that state piece that pushed across, do you see what I mean about wave-like energy that's created? And as these get bent, guess what they send? When they get bent, sodium pours in, potassium pours out. What happens at the membrane? A shock. And as that shock gets sent through that cochlear nerve to the temporal lobe, we interpret it as what? Sound. Right. Okay, so again, a mechanical version of this can sometimes really help you with that. And again, as these get bent, we said action potential. I'm not going to ask you about the action potentials, but have y'all heard about action potentials? Where'd you hear about them? Exactly. Thank you so much. Is it any different, really? The physiology? No. So, we talked about that it's really the temporal lobe. Now, equilibrium, we said, is that head of the snail. You see the head of the snail here? This vestibular apparatus, vestibular complex, this vestibular body, these semicircular ducts, vestibular, right? So these are filled with fluid too. And in this fluid, in these semicircular ducts, this fluid, it has these microscopic little bones. They're referred to as otoliths. These little tiny little bony crystals. So as the fluid moves over the nerve endings of the vestibular nerve, is it hitting them and pushing them in certain ways? Yes. So when people have vertigo, does everybody know what vertigo is? I hope I never really know what vertigo is. So anyway, because I've seen people just sick. They'll fall down, they'll be vomiting, and it's all because they're dizzy and they feel like they have this motion sickness happening. It's miserable. So what is happening is that these little otoliths are getting stuck. So even though the person is sitting upright, and still do they feel like they're moving. Mm-hmm. Yeah, so their brain's turning to movement and they're obnoxious, they're sick. So what's been really effective, instead of just drugging them out of their mind so that they're knocked out in the coma in the bed, is actually repositioning their heads, doing positional therapies. Anybody ever know anybody who had positional therapy because of vertigo? Nobody in here? You've had it yourself?
My grandma, she had vertigo, and they gave her like a sheet of different exercises.
Yes. Yeah, and staying in certain positions. I'm doing this because this is one of them. You're supposed to lay on your bed and have your head back off the bed, your shoulders on it, but your head completely off of it for however many minutes, and then you move in a different position. So it's sort of like, those little games where it's filled with water, there's a little ball, and you're trying to get that ball, and you're doing that with your head. And it's because of these, that sounds really bad, but that is exactly kind of what's going on. And that's gotten very good results. So equilibrium. Let's take a break, and we're going to come back and look at sight, and we'll be done. But let's take about 10 minutes. Is 10 minutes enough? Or do y'all want to get something to eat or something? 10 minutes is good? All right, so 10 minutes.
Probably my grandfather married in, but he was from the north, and my step-aunts are from the north as well. So, and
Okay, guys.
I hear accents.
We were talking about north and south. Switch.
And butt whooping. She didn't.
I didn't know she had never heard of a switch. We were talking about the other day another.
From the north.
Yeah, I know that. But I was just like, if I cannot do that, why do people on my house? You can play soccer, you can do this, you can do that. There was that probably hurt you worse than What?
That probably hurt worse than the tail would.
Well, we didn't do that. I didn't know what a switch was. They were talking about it in class, and I was like,
I'm sorry, I did not mean to
no, that's fine. Yesterday it was like they were talking about it in class. I was like, and I don't want to be like,
Which class?
so then I'm just like,
Oh, yeah. Okay, guys, look, so the recording's on because there are a couple of people out today, and I want to make sure.
Just a moment ago, the whole time.
Yeah, pretty much. No, so anyway, but I want to just make sure that the people who are here, because I just got a really good question a second ago, a question about what's coming up and what we're going to do. So I want to make sure that everybody's on the same page and understanding. So on Thursday, and by the way, everybody has to be finished everything Thursday afternoon, or it has to be a 0, because I have to turn in grades Friday. I don't even have any say of that. That's with this 8-week session. Grades have to go in Friday. So people are out too, they need to be hearing this maybe. They're listening. Everything that might be missing, if we've missed a lab or a test, I don't think that's just a test at this point, but if you've missed a lab, then you have to have it done by Thursday before you leave here. Thursday is our testing day to finish up. When we come in, the first thing we'll do as a group, we need to do it together because we want to go over it together, is the nervous system test. So I just got the question about what's on the nervous system test. So what's on the nervous system is going to be it really ends up being chapters 12 through 16. But it's y'all, what do y'all trust me now about the questions, how I ask questions? What do you study? You study what we lectured,
And deeper insights. And
deeper
Disorders.
insights and disorders. Will there be a question on anything else?
No, and if it is, you do it.
Okay, y'all are sounding like I'm a broken record, but some people worry about what to study, so that's what to study for the nervous system test. After we do that test as a group, and everybody, the last person's finished it, you know, in the past it's taken 45, 50 minutes. We go over it together. And the reason we need to go over that together is so that if you miss anything that was a deeper insight or disorder, you understand why you missed it, you understand what the right answer is, because might you have a question that's similar on the final exam.
Yes.
Yeah, and I don't want you to miss it on the nervous system test, and then as we're going over it, not paying attention to that, and then miss it again on the final exam. I just don't want that to happen to you. So we go over it together. After we finish that, and everybody's had a chance to review their results for that, then we are going to, you've got a few little labs to label. I've already sent it to the printer, and I'll be able to get it after we finish these notes today. But I'm going to give you a word bank that's of the structures that you need to know for the eye, the structures you need to know for the ear, and the structures you need to know for the brain. I'm also going to start with that here and go over it again here on the recording and point out each of the structures that you would need to know. So then you'll take your labs. So after, and you can take a break in between. I don't care. You can come to me and say, I'm ready for the brain lab. Or you can, Andrea can come to me and say, before that brain, I'd like to do the eye and the ear together. So I'd like to do the eye and the ear lab. Fine. So this classroom is for testing that day. You can go away and come back. I'm going to be in here for like 4 or 5 hours that day, just in this classroom, squatting. No, not literally, but just like, like taking over this classroom, right? And then I would want anybody, and then you can, when you're ready, you can take a break and go and review those insights and disorders, because the final exam is on what? The deeper insights and the disorders only. And so when you're ready to take that, you can come take that. We do not go over that as a group. So when you take that, that'll be the last thing you do for me. You'll hand it in and you're done. You can go. I will have the grades in before I leave. I'm going to try to have the grades posted to Canvas and to the SIS system, but sometimes that doesn't go over until overnight, before the end of that day. Because on Friday, I'm supposed to be at a conference. Yes, and grades have to be in on Friday. Rayana, you raised your hand. Yes, you did. Yes, you did. I'm sorry.
The deeper insight, which chapter is going to be Friday?
Is it all the
The deeper insights are in every chapter. And the disorders table started with chapter 6. They didn't they?
So it's
Started with the skin. Yeah. The disorders table started with our organ systems. Remember that? Y'all remember the skin? So that's where they started. So, and y'all have been studying those as you've been going along. Isn't that right? Now, I seriously need you to ask me if there's any questions, because this would be the time. So Thursday is really just a testing day. The thing that we have to do together, though, at 9 o'clock is that nervous system test. After that, you can come and go and take the rest of them as you want to. You just have to be finished by 1. Yes, Jada.
I don't know if this is a stupid question.
No, there's no such thing.
Is it a picture of the ear? Like, is it pictures or is it like how it works?
It's not a stupid question at all. And I usually try to tell you how the labs are going to be, like, like with the bones, and like you all were expecting on the muscles today, aren't you? Is that what you were expecting on the muscles? So good question, Jada. Great question. And here's what it's going to be like. It's going to be a picture like this. Ready? So for the ear. So here it goes. Let me give you the structures I would want you to know in the ear. And will I be giving this to you also in a sheet before lab today? Yeah, it's going to be a sheet of paper that's got the brain structures that you need to know, the ear structures, and the eye. But here's the ear. And this is going to make better sense to you because we just went over it, right? But I would want you to understand that the auricle is what? The ear. It's really just this outer ear. It's the shell of this ear. So auricle, auditory canal, tympanic membrane. What do you call the tympanic membrane? But are you going to know tympanic membrane? It's the same thing? And you're going to know that it's this eardrum, isn't it? I want you to know that, and you can either be writing these down right now, or you're going to know I'm going to give them to you in a list. It's not everything, but it's most things. Malleus, incus, and the stapes. And do you have to know which one is which? Yes. Yeah. Malleus, incus, and the stapes. I wanted you to know this auditory canal, this auditory tube, tube, because this is a tube, isn't it? This tube is also referred to as the what? Eustachian tube. So know both of those terms, eustachian tube and auditory tube. Then what was this called? The body of the snail? Oh, the snail is the cochlea. And what was this whole little part called? It's called here the semicircular ducts, but what do y'all know this is? The vestibule. Yeah.
So on the paper, you're gonna have just
I think on my paper it says vestibular apparatus and then semicircular ducts. So it has a duct. Well, y'all, hey, could y'all actually take that right now?
yeah.
Yes. Why don't we do that? Just to get it over with. Let's do it as a group. No. No. Because I want you to look at it. And I want you to look at the model today. The model was really cool. I spent, I had to go spend a lot of money on that model. I want you to look at it because it's really kind of cool to think about, right? All right, so do you have any questions about, I didn't give you everything on here, did I? But you feel pretty good about the things I had on here? Now, when I give you the list in just a little bit, if it's got something on here I didn't just go over, you can remind me. You're going to say, what the hell is that? No, maybe you won't say that. But you might just say, what is that? So, but you let me know. So it's going to be a picture, Jada, and everybody else. It's going to be a picture. That's a great question. Now, here's what I'd like to do. I'd like to actually, even though I've got a list for you for the brain structures, but do y'all mind? Let's go back and let's see. Let's see that brain, because there are. I just want to make sure if we went over it today, as a group, y'all would feel okay. Yeah, we did this, right? We talked about these structures, and you would feel pretty good about it. All right, do you feel like do you feel like you might end up getting a mid-sagittal section of the brain?
Yeah.
Okay, I think so too. I think you're probably going to get a picture that looks like a mid-sagittal section of the brain. Everybody knows what I mean when I say mid-sagittal section. And would it be fair to ask you about the medulla oblongata?
Yeah.
And what's right up from that? Pons. This area is the midbrain, and I'm not sure I gave you that, but this is the midbrain. These two areas together were called the what? Brainstem. But this was the midbrain. And what was this area right here? That's the gateway, the gatekeeper. It's the thalamus. Remember that? Now y'all don't have to be writing them down right now, because you know, just use this as our time. We're looking at it, we're making a visual of it. We're saying, yeah, okay, that's not foreign to me. I've heard that word before, and it's going to be on my list. So we good again? Say this again out loud.
Midbrain, thalamus, hypothalamus,
Pituitary. And what was to the back? The pineal gland, right? Now, that's great. That's great. Y'all feel good. There's something I didn't tell you, but it's on your list, and I don't think I actually said it out loud, but I want to do it now, so it's fair. There. So here we go. Ready? This, when you cut the hemispheres, the right from the left, and you're looking at a mid-sagittal section, what's connecting the hemispheres is this thick, and it looks white tissue. It is white matter. It's the corpus callosum. The corpus callosum. You know what's really cool, ladies? Females' corpus callosum. This is the highway between the hemispheres. This is how the hemispheres messages are getting sent between. This corpus callosum is thicker in women than it is in men. I don't know what that means. We don't really know what that means, but we know it is. And so, you know, do you think, when you think about that, isn't that kind of cool to think about? Because men and women do think differently, don't they? And actually, when we think, what we know from studies is that women multitask, whether they should be doing it or not. Women multitask way more often than men do, and men won't usually do that, you know. And that doesn't mean that makes women better or stronger or whatever than men, because actually there's some downsides to doing that and not being able to just say, no, I'm doing this right now. You know what I mean? Mm-hmm. So women tend to do that. Do you think it might have something to do with that thicker corpus callosum? I don't know. But it's been suggested that it has something to do with it. Anyway, what is this connection that connects the hemispheres? What is it called right here? This thick corpus callosum. Y'all gonna know it? Cool. Y'all also told me, and you don't have to do it in this because Jada, thank you for bringing this up. There will be pictures. You don't have to do it from a mid-sagittal section, but do you all know what this is here? It's the cerebellum. Cerebellum. And the lobes of the brain are the what? Cerebral. So that all the lobes are the cerebrum, and this is the cerebellum. Exactly. Now, if we looked at the lobes, now this is just a lateral view of the lobes. The cerebrum. Is the cerebellum removed here in this picture? But these are all the nice colored lobes of our brain. We know that from here, this is called the central sulcus here. It separates the what lobe? From the what? It sure does. It separates the frontal from the parietal. So we would, all of this blue, violet, whatever that blue is, that's frontal lobe, isn't it? And all of this purpley is what? Parietal. And this green, and this whole temporal. You all know the lobes of the cerebrum? Yes. Fair? Yes. Okay. Are we good? Yes. All right. You know the functions, just as a review. We know the frontal is personality, also motor, voluntary motor, right? Personality, voluntary motor, We know the Broca's is kind of right in here too. But the parietal was sensory. This was sight, hearing. And we really think about smell, hearing. We know the limbic system is close to here, so the limbic is going to be hippocampus and amygdala, right? Okay, so great. And actually, then we said, and I couldn't have given this to you in a more suggestive way than I did. I asked you to make sure that you looked at the pictures of the meninges, didn't I? I asked you to actually specifically look at this one, didn't I? Okay? And for the meninges, we know meninges are what? Membranes surrounding, encompassing, compartmentalizing the spinal cord and the brain. Spinal cord and the brain. And we said the one that's sitting on the brain, this real thin little film, the one that's closest in contact with the brain is the what? The pia mater, right? And the one that's really thick, they're making it look like whatever, but it's really thick, that's right under the skull, is the what one? The dura. And then the one that's sandwiched between the dura and the pia that has like little webs. Arachnoid, because arachnoid means what? Spidery webs. You see the little webs coming off? That is the arachnoid. But you need to know the three. Yeah. They're going to be on the list. They are. They're going to be on the list. The pia, the arachnoid, the dura mater. They are the meninges of the brain. You guys, there's nothing else on the list that I haven't just gone over on the brain. You feel okay? Mm-hmm. Do you have any questions? All right. Now, it's the eye is the last thing that we're going to do, and we get to dissect an eye. I hope y'all are excited about doing that because there's some little sheep that donated their eyes to you for this. And I think I count eyes too, but whatever. So, but, you know, so we're going to be looking at the eye. We are going to be looking at an actual eye, not the external. But look at this external eye. Do we label everything? Oh my gosh, we have a label for everything, don't we? Anatomically. But this is not what you're going to get. What you're going to get is going to be, I'd really look at this one if I were you. I mean, I take a look at this, and this one's going to make more sense to you after I go over it. But right now, I'm telling y'all right now, this would be a good one to kind of look at, right? Something that looks like this, where we're actually really just seeing the optic nerve leaving the back of the eye, and we're actually seeing the eyeball itself. We're not going to really, I'm not going to give you like the muscles, am I? Or the external anatomy. So we're not going to do that. But anyway, so how do you feel? Do you feel a little bit better about those labs? And when I go over the eye, I'm going to go over those structures. After I've talked about them, I feel like giving them to you now. Let's put it in the cart before the course. But you ready to start talking about sight? So what we understand is we have these special types of neurons that can be innervated by photo wavelengths, light wavelengths. And when we think about light wavelengths, we understand y'all have all heard about the visible light spectrum, right? So what we know is light waves are hitting the planet, and these waves that are actually measurable from peak to peak or trough to trough, they're measurable. And, you know, they're in these little units, if you will. They're actually called photons. But if we measure, and you could measure from peak to peak, or you could measure from trough to trough, the measurement would be the same, you know, depending on the photo wavelength. We understand that the visible light spectrum, and I hope, do I not have a picture of the visible light spectrum? Do I? Y'all have it in your book. But the visible light spectrum is going to be measured from roughly about 400 nanometers to about, and I think your text is saying 750, but it's really just a little over 700, if you will. It's 750, that's fine, nanometers. So that means if these wavelengths, the ones that measure from this to this, they can innervate our photoreceptors. They're in the visible light spectrum. The ones that are shorter than this, these have a lot of energy associated. If this was 400, if this was 400 here, then it can innervate our photoreceptors. The ones that are much shorter than this, we can't see, but they have a ton of energy with them, and it can actually sometimes be, y'all have heard of ultraviolet energy, then you've heard of gamma rays and X-rays. These have a lot of energy with it. The ones that are longer, that's so exaggerated, but the ones that are longer, again, the ones that are greater than the 750, we can't see. They don't innervate our photoreceptors, but what they do is they have less energy. So when you think about microwaves, right, and radio waves, they're these long waves. You with me? Okay. But the visible light spectrum are light waves that are coming in that measure within this. That makes sense? Okay. So for light to be able to come in to those photoreceptors, they need to be able to move through clear structures, because if something's not clear, could light get through it? Or would it be blocked? Right? It would be blocked. So does it make sense to you that this structure that's the outermost structure of your eyeball itself has to be clear? It has to be perfectly clear, or it should be. And light can move through. So we're going to talk about that in just a minute. But what we need to kind of get to is that for an eye to be healthy, we do need this external anatomy. Do eyebrows and eyelashes serve a function? Yes. They keep things out of your eyes, don't they? They do. They keep things from getting into your eyes. Do we have a lot of nociceptors in our eye? Yes. Why? To keep things out of your eye. Because if there's something in your eye, you'll know it, won't you? You'll know it. You'll be alerted to it. Pain is a good thing. It alerts you. It lets you know that there's something in there that could impair your vision, the light being able to move through, and then could you lose sight? So having things hurt your eye is actually protected. Has anybody ever had an eye injury? Really painful, right? So it's painful, and or if you've had something in there, you've heard of people scratching the cornea and being in such excruciating pain. But anyway, so we know they keep things out of your eye. How about if we looked underneath that right here? There's a gland. What is that gland called? It's called the lacrimal gland. What do lacrimal glands secrete? Tell me, because you'll need to know. Tears. Lacrimal glands secrete tears, don't they? You would want to know that. And as tears wash across your eye, now you're secreting tears 24/7. You're secreting tears 24/7. As they wash across the eye, they're keeping the eye moist. They're keeping it clear. They're keeping that tissue healthy. In your tears, you have antibodies that are doing what? Protecting you, right? They're actually fighting off potential pathogens. So do you need to be producing tears all the time, 24/7? Yes. Now, if you start producing too many, what's going to happen? They're going to sort of run over and run out, whatever. It's going to run down this little duct into your nose, and your nose is going to start running and whatever. But better to have too many than not enough, because we don't want dry eyes either, do we? So anyway, we get that you have glands that also going to secrete some oil, because is that a bad thing or a good thing? Again, just keeping the eyes healthy, aren't they? Now, if you've never heard this term, make sure you know it. This is called, this structure is a conjunctiva. And what I want you to know about the conjunctiva is it truly is a transparent, what does that mean? Yeah, it's a transparent, but mucous membrane. It's very, very delicate. That's lining the eyelids and covering the front surface of the eyeball, except for the cornea, all the way up to the cornea. Now, you might not know where the cornea is yet, but let me show you from here. So all the way up to where the iris, the colored part of the eye is, the entire whites of the eyes, right? So this is a membranous layer that is covering those inner lids and the sclera, which is the white of the eye. The sclera is the white of the eye. And we said this is actually, this membrane, this conjunctiva, if you've ever seen somebody who had bloodshot eyes, what were you really seeing those vessels in? What membrane? The conjunctiva. So what do we call, what is conjunctivitis? It's inflammation of that membrane that's lining the eyes. It's inflammation. What do people call it? They call it pink eye, but it's, you know, infectious diseases, we don't really like that, but they do call it pink eye. Most common cause of pink eye? Thank you. The next most common cause? The rarest of causes, bacteria. In infectious disease, we call pink eye the bacterial conjunctivitis. But let me tell you the difference in bacterial conjunctivitis and just viral conjunctivitis. Bacterial conjunctivitis, the lids are closed, and it is green-brown goop, and they are painful, they're hurting. Most people who have conjunctivitis, it's allergies, it's a goldeny kind of crusty, you know, discharge of the eye. It can be a little creamy, but whatever. And viruses too can do that. So rare is it that really someone has bacterial conjunctivitis.
So if you're right, if a resident wasn't pooping around, that would be bacterial, right?
What did you just say? What did you say?
I have a resident who is constantly putting like a potato with her hand and playing in my eyes. And she stayed with
So this is why, you know, we have antibodies in our tears. We have antibodies in our tears. We have these built-in protection mechanisms to reduce the chance that something like that can cause conjunctivitis. But if it's overwhelmed, can it cause conjunctivitis? If something gets overwhelmed, yes, it can. So yeah, but usually conjunctivitis, when we see bacterial, it's going to be from those microbes that are in somebody. It's not fecal. It's not usually fecal microbes that cause bacterial conjunctivitis. It's usually the ones that can be in the back of your throat. And why did we say that that makes perfect sense? Because can they travel to there? Yeah, they can. It's all connected. The eyes, the nose, the ears, right? This is why this is also a huge portal of entry for pathogens, portals of entry for fecal coliforms to cause other worse things than just conjunctivitis. Not that conjunctivitis wouldn't be bad enough, you know, but definitely. All right, so everybody knows what conjunctivitis is and what causes it, don't you? All right, so now I think we're ready. We're really kind of ready to look at the eye itself and think about the anatomy of the eye. So everybody know what this perspective is. We know that this is where we're coming from this direction as far as with light waves. So light waves are coming in here, right? Light waves are coming in here. If there's any light available, you know. Now, can humans see in the dark? Huh? Not easily. And if it's really dark, can we see it all? No. So there needs to be a certain amount of light. We are not nocturnal creatures. We're not. We cannot see well in the dark. You know, we will run into trees if we're being shades, and we will step off of cliffs because we won't know they're there. You know, so we really can't see in the dark unless we have, you know, we have artificial lights now. But anyway, so light waves are coming in to this. So this is it. I just wanted to make sure y'all all understood that this is like the front of the eye, and this is the back of the eye. And we've already talked about the optic nerve, haven't we? We've already talked about the optic nerve. We know that this is a cranial, because we have two eyes. Cranial nerves that actually make sure that we have sight. So they're exiting the back part of the eye. Today, when you get your eye, I want you to feel first when you look at the external anatomy. I want you to feel that little nub of where the what got cut. The optic nerve got cut. It feels really kind of cool. Okay, so feel that nerve. And then I want you to just take a look at the external anatomy of the eye. Look at it anteriorly. as well as laterally, and look at the back of it for the optic nerve. Just take a look at it. Now, what you're going to end up seeing, and y'all's the eyes that you have, some of them actually do still have the external lids and lashes, so you might want to just cut all that away. Some of them you might see some muscle, but we're going to just really mostly be looking at the eye itself. Now, we said that the white of the eye is called the what? Sclera. And this is referred to as a scleral tunic. A tunic is just Latin for coat. So that's that external coat layer of the eye is called the sclera. Do you see it right here? The sclera. It is tough. It is a tough coat. It really is. And thank goodness, right? Thank goodness for that. You're going to take your blade, and if you want to, because you can dissect your eye any way you want to, but I think it makes sense to dissect it by taking the structures and dissecting the structures that you will have to label. So you'll see that this sclera is continuous with a clear structure that covers the colored part of the eye, which is the iris. But when you take your knife and you take it superficially and try to cut into that cornea, because that clear, transparent structure that's continuous with the sclera is called the cornea. You're going to try to remove the cornea, and the cornea is completely covering the colored part of the eye. There is a little chamber, a little space, right? A space between the cornea and the colored part of the eye, the iris. There's a space. And in life, that space is filled with fluid. I want you, and this is the only thing I'm going to get you to add to these pictures because it's not labeled on here. But I want you to know that when you cut into that cornea and start to cut around that cornea and trying to remove the cornea from the iris, and you're going to have a little space between, that space is filled with fluid. It's called aqueous, because aqueous means what? Aqueous humor, and humor means what? Fluid. So that's redundant, isn't it? That's like a redundant thing. Aqueous humor is fluid. So it's water fluid. Okay, it's mostly water, and you'll see water kind of pour out. A few drops pour out. So again, this chamber is filled with water, and should that water be clear? Yeah. Because we said what's having to come into this cornea? Light waves. And when they come through, do they want to be impeded by anything cloudy? No, so they'll move through this front chamber. Y'all see, how did I know that was a front chamber? What's the word? Anterior chamber. They'll move, the light waves just move through. And then they move through a hole. This is a hole in the iris. This hole in the iris is called the pupil. You call that little black center of your eye the pupil. You might have thought it was an actual structure. It isn't. It's a hole. It's a hole. Just like when you look up on the side, you're hiking and you look up on the side of the mountain and you see this hole in the side of the mountain. What is that? Or you see this black thing on the side of the mountain. It's the opening of a cave, right? And why does it look black to you? Why? Because light's going in, but no light is escaping out of it, so it appears what to you? It appears black to you, doesn't it? So the pupil, your pupil appears what to you? Black, because it's an opening, it's a hole that light is going into. Do you see the light going into it? Do you see it? You see it? Light's going into it. See how light's going into it? And it's not coming back out. All right, that's the pupil. So if I were you, I would take my blade, you don't have to, but I would take my blade and I would do a superficial coronal cut and remove my cornea. And then when I remove my cornea, I understand that there was a chamber, that was filled with aqueous humor. But now I can see my iris. The iris is the what? The colored part of the eye. And then you can take your knife and go around that iris, and can you remove your iris? Yeah, and in the center of the iris, there's a hole. What do we call that? All right. Is everybody good so far? Is everybody good so far? All right. You're going to see that there is a structure right behind, right underneath the iris. Y'all see the iris here? Everybody see that this is the iris here, right? There's going to be a structure right underneath it, and in death, that structure hardens. In life, it's way more flexible. In life, it's way more flexible, and in life, it's also clear. So, but in death, it hardens. And as we age, it actually hardens. This structure is called the lens of the eye. The lens. And we know that in life, if this clouds up, this lens, what do y'all call that condition? Cataracts. If this lens that's going to look like a little marble to you today, going to be kind of hard, please try not to. Don't think you're going to dissect that lens. And I'll have somebody do it anyway, but don't because the blades can break. But those lenses, in death, the cornea is clouded. Because in life, we've got these processes happening, keeping our corneas clear. Every day, we are removing things from our corneas to keep them clear. If the cornea were to cloud, would that be a problem? What can cause the cornea to cloud? Infections. And the infections can range from bacterial to protozoal to actually worms. Like I know, I get it. I get it. So anyway, but we want our corneas clear, don't we? And do we want our lenses clear? Yeah, because they have to be clear. And in life, we keep them clear. But as soon as someone dies or an animal dies, those processes stop. So the corneas become cloudy. Like today, your corneas are going to be really cloudy looking. And instead of transparent, they're going to look more like translucent, you know. And the lenses, are the lenses going to be cloudy today when you remove those? But in life, they're not. All right. So we get it. Light's moving through. It hits the cornea. It goes through that front chamber. It goes through the pupil. It goes through the lens. Light waves are moving, right? The whole back of the eye, this illustration makes it look like this is solid. But what this is, and I actually wish they didn't call it this. It's called a vitreous humor more often than not. This is called a vitreous humor. This back chamber is huge, isn't it? The back chamber of the eye is huge compared to the front chamber, isn't it? This back chamber of the eye is filled with a jelly-like fluid called vitreous humor. And it's filled with this, it almost looks like raw egg white. Yeah. So like raw egg white. This whole chamber is filled with that. In life, should it be clear? Absolutely. It needs to be clear. Because what's moving through? Light waves. Have they hit anything yet? We hope not. We hope they just move through. We hope there's nothing that they're really hitting. Because when light hits something, does it get refracted? Yeah. Yes. It gets refracted. Y'all know that. So, okay, so light's moving through, and it gets all the way, it gets all the way to the inside of the eye. It gets all the way to the back of the eye. The inner layer, does that make sense? The inner layer of the back of the eye. This inner layer is called the retina. That's the retina. So you're telling me that the first thing light waves should hit is the what? On what membrane? It should hit the retina. Guess where all your photoreceptor cells are? You think I'm going to ask you that? Yeah. All your photoreceptor cells are in your retina. Where is the retina? It's the innermost layer of the back of the eye. It makes sense that they're all there because light waves are moving through to the back of the eye. And as they move through, I really kind of do want you all to notice this. I think this is what comes. But as light moves through, it does get bent when it hits something, so it gets bent. But light waves are moving through. And does it make sense that they would hit this back layer of the eye? Does that make sense? It does make sense, doesn't it? Because they haven't hit, these structures should be clear, so the lights just move through them. Yes, they've been refracted somewhat, because the cornea is curved, isn't it? And I'm going to show you, like if you think about how light hits the cornea right here, it gets refracted just enough to get into that pupil, if it hits up here, it's being refracted, right? And the curve of the cornea makes it so that most of the light waves hit in a very special area in the retina, and that area is called the central fovea. Central fovea. It's called the central fovea. It's also referred to as the macular region of the eye. The macular region of the eye. I am looking at Jessica and light waves, lights hitting off of her, and lights going through my cornea, through my anterior chamber, the aqueous humor, through the pupil, through the lens, through the vitreous humor, and hitting on the back of my eye. And I want y'all to all look. I'm looking at Jessica, and I can see details about her hairband. I can see details of her eyebrow shape, and I can see details. Now I know that's Alexis. I'm still looking at Jessica. I know that's Alexis only because I know she's sitting there. And Kelly, I know that's Kelly too, but I don't have great detail on Kelly. I've got details of Jessica's face. Are y'all with me on this? When you're looking straight ahead, the center vision, where you have your best visual acuity. Are y'all hearing me? Your best visual acuity is because those light waves are hitting one area. The macular region, which is also called the what? Or the fovea centralis if you're Latin, which not too many people are, but you'll hear it's called that too, central fovalis, fovea centralis, or central fovea. So anyway, do y'all see that? What would happen? What would happen if I started losing the macular cells in my retina? That macular degeneration started happening, and I started seeing a black spot in the center, and it started to get enlarged. Would I have any detailed vision left? When I start with it, that's called macular degeneration. That's macular degeneration. It's the most common cause of blindness in the aging in our country today. And there's a couple of different types, wet and dry. Does anybody know anybody with macular degeneration? Yeah. Can you imagine how very sad if you could never look at details on a person?
Yeah, it was Josh's. I told her, I said, just so you know,
Oh,
because because by that time she was just blind. She's legally blind.
She's legally blind. Okay, so some things cause us to lose peripheral vision first. If you have too much pressure from this aqueous humor, you're making aqueous humor every day. But if you're making it every day, you better darn well be able to be doing what every day? Reabsorbing it, right? Because you've got to keep this pressure balanced what it needs to be. Because if you're putting pressure on these photoreceptor cells, they will what? They will die, right? So the pressure has to be maintained. You're making it every day, you're reabsorbing it, you're keeping the balance what it needs to be, because the balance from the front chamber is actually also putting pressure on the vitreous humor, which is holding the retina in place. Y'all are going to see today when you get that jelly-like stuff out of the back of the eye, the back chamber of the eye, that jelly-like humor was holding the retina in place. The pressure has to be just right. There are these fragile cells back here. If there's too much pressure, you're typically going to lose the photoreceptors. Look at somebody just straight ahead in front of you, and y'all do this for a second. Put your hands beside, like 90 degrees, and then start pulling your hands to the front. Don't move your eyes though. Look straight ahead, and tell me stop when you think you can see your hands. All right, so you can see them way before then, Mariah, can't you? Put them back a little bit. You can see them way before here, can't you? Can you not see them until they're right here? Because, okay, you can see them way back here, can't you? Because if not, then you might have glaucoma. Because if you're losing your peripheral view, that's called glaucoma. That one of the things is glaucoma that does that. And it's because of pressure being exerted on this vitreous humor that's holding the retina. So that's when you're starting to lose peripheral vision. Macular degeneration, you're losing the vision when you have the highest areas of visual acuity. which is going to be in the macular region, or what we call the what region? Central fovea. Exactly. All right. Any questions for me? No. All right. So the retina holds all of our little photoreceptor cells. Today, and I hope you all will appreciate it as much as I did when I was first dissecting eyes, which was many years ago. But you guys, there's two things that I kind of remember, and this was one of them that I was most blown away about. Because thinking that your sight is because of these photoreceptor cells being innervated first, sending signals to the optic nerve, sending signals to the action potentials to the optic nerve that's going to the occipital lobe, right? And your photoreceptor cells are all in that retina. I couldn't believe how fragile it is. It's crazy fragile. And the only thing holding it is that jelly-like stuff. It's holding it in place. Have you ever heard of a detached retina? If somebody has a detached retina that completely detaches, they're blind, they're 100% blind in that eye, and it is never coming back. There's some clues that their retina might be detaching. Sometimes it happens instantaneously. There's nothing that can be done. And there's not just a little losing of sight, it's gone. Sight's gone in that eye. Some warnings of a detached retina can be floaters in your field of vision. Now wait a minute. Some floaters are normal. How many of you have floaters in your field of vision? Floaters are because of cells that slough off, that get in the vitreous humor. So as light moves through, they hit a cell which casts a shadow on it. And that's why you see these floaters. You get what I'm saying? So most floaters are benign. But if somebody has floaters, should they get them checked to make sure that it's not a retina, the retina detaching? Do you get what I mean? So it can be a sign of a retina detaching. I just did that with one of my peers, one of my friends who teaches here. He said, I got this thing happening. And I was like, you need to get it checked to see if the retina is detaching. He said, but so-and-so said today. I said, I know, but you just got to get it checked. And his is. So they're watching it for the next week or two. And if he has X, Y, and Z, he has to go immediately. But they might have to surgically repair that retina. They're hoping it's going to reattach. Because if it doesn't, and he loses it, he's not supposed to pick up anything more than 5 pounds. He's not supposed to, do anything that's going to jar his head. So sometimes people have detached retinas because they have a really hard hit to their head, and it's just enough. Some people diving, they can do trauma to the eyes, and it can, they think that can actually set you up for it, but whatever. All right, so you good? Everybody's good with that? Understanding that? Underneath this retina, there is a layer today that you're going to see that looks black. It's really thin. It's going to look really thin to you. It's going to look black, fluorescent-y, beautiful, actually, layer right underneath the retina. The retina is going to be sort of anticlimactic to you because it's going to be kind of boring looking. It's going to be kind of beigey. It's going to be sort of like a gray sweatshirt that Nicole's got on, and really thin, and it's going to be wrinkly, looking because it's already starting to collapse. So the retina looks boring, but does it have all our photoreceptor cells? Yes. Underneath that is this choroid layer. The choroid layer is the layer that's got all the vessels that nourish the retina. So is it an important layer? Mm-hmm. In this picture, it's looking kind of pink here with blood vessels. Do you see what I mean? This choroid layer, it's kind of pink. But for you, it's going to look black and fluorescent-y colors. And the retina is going to be very, very fragile, the innermost. Do you have any questions for me about this anatomy? So could you label the cornea? Yes. Could you label the anterior chamber with the aqueous humor? Yes. Could you? Could you label the posterior chamber with the vitreous humor, which is jelly-like? Could you label the lens? Yes. The pupil? Yes. The iris? Yes. The sclera? Yes. The retina? Yes. The macular the macula central fovea. Could you label that? The optic nerve? Yes. All right, good. You're going to be great. And we've talked about all of them. Now, I've also talked to you about some disorders, right? So what I want to do at this time is there's just a couple more things I want to talk to you about. This is showing you, you got all kinds of pictures you could look at. You got a lot of time, if you got a lot of time. Wait, how many of you have ever had a light sit back to your eye and really are looking around at the light? Everybody's had that? So looking with a scope, ophthalmoscope, and looking back here, this is the only area on the anterior part of the retina, because you can see, you'll see today how fragile that retina looks. You can see right through the retina to the vessels in the choroid. And someone who's doing an eye exam with you, this is the only area in the body that you can actually directly see blood vessels. Now, I know you through your skin, you're seeing stuff, but this is direct. You're really seeing these vessels. This is why sometimes you can have an eye exam if somebody, you know, not for me, so I wouldn't know what to be looking for, but it's a specialist, an optometrist or an ophthalmologist. You can go in for an eye exam and they can diagnose you with diabetes. And they can diagnose you with hypertension or other things because they can directly see these vessels. That's pretty cool, isn't it? So this is what I mean about this, the fovea centralis, and this macular region is all kind of right here, where you want most of those photoreceptors, those photo wavelengths hitting right in this area. Where the optic nerve leaves the back of the eye, does it make sense to you that where it leaves the back of the eye, there can't be photoreceptors there? So that's what's called your blind spot. That's what they call your blind spot. That's just kind of FYI. Now, everybody told me they get that if light hits something and there's a curve to it, it's going to be bent. It's going to be retracted. Everybody said that. They kind of understood this. But we said in a perfect scenario, it's curved just right so that these light waves are going to be concentrated. So by the time they hit this macular region, the fovea, they're going to be really, really concentrated there. And this is where we get our most detailed sight. Yes, we have other photoreceptors, but this is where we get our detailed sight. So does everybody also get that your eyes need to move since you have two eyes, and they need to, or you know, to see something up close, they're going to have to be able to move, and then obviously move away, right? Move to coordinate that. When that is happening, when that is happening, the lens is also changing shape. This lens will be changing some shape. So in light, our lens, to be able to see up close, and you're going to have a picture of this in just a second. You'll see the lens is going to be kind of thick here, but what did the lens do here? So as we age, our lens loses some flexibility. And this is actually called old age farsightedness. How many people do you know that are doing this as they're aging? Right? Yeah. This old age farsightedness is because the lens is losing some of that flexibility. My husband wouldn't admit it until like the reading was across the room, almost. No, not really. No, not really. But he was getting very far away. So from it before he would admit it and had to get something. This is called presbyopia. Presbyopia, this is in your books and in your notes, but it's called old age farsightedness is presbyopia. And what is it really? It's just really kind of a loss of flexibility with this lens, right? You also have something called farsightedness. So I do want you all to kind of know, kind of understand that, you know, you do have this. And I'm just going to let you read it because I'm not even going to try to say that. But that's like farsightedness. But there's also something called myopia. What does that mean? Nearsightedness. And what is actually happening with that is instead of this nice area being hit right here, so the light waves are hitting right here, they're actually still spread out here, and there's this imaginary plane of where it would have to be for them to be hitting. So since they're spread out here and not concentrated, that's why you don't have, like you can't see well, everything's fuzzy. But if you get corrected lenses to correct that refraction, well, you see well. Sure. And same thing with nearsightedness. With nearsightedness, the eye, the refraction's happening, but the light is hitting somewhere here in the vitreous humor and then continuing. So again, is it spread out by the time it hits the fovea? Spread out. So you can't see well. Everything's kind of fuzzy. But if you get corrective lenses, then that's what they're trying to do, right? So hyperopia, myopia, this is going to be near and farsightedness. Presbyopia is old age, farsightedness. And let me think of what else I want you to know. I want you to know the photoreceptor cells, there's two types. There's cones and there's rods. I know you all have heard of this before in whatever, elementary school probably. But the reason they're called cones and the reason they're called rods is what? Because they really, this is an electron micrograph. They really look, the cones look like what? And the rods look like So what I would like you to know is that there are two types, the cones and the rods. And the rods are for dim light situations, And the cones are for, bright light situations. The cones are for color. We can see distinct color. Like there's enough light in this room that I can see Kristen's the color of her jacket, right? Red. But if I turned off the lights and if I pulled these shades, would I be able to tell colors? Actually, y'all all know, like if you turn off lights in your house and then you can still walk through your house after just a minute, but you might have to stand there, until what starts taking over? The rods. And then you're going to actually, with the pigment that starts with the decreased light situation, then you're going to be able to make out shapes, aren't you? And you're kind of going to be able to make out shapes. You might run into some things, but you would be able to get through, right? But in highlight situations, the cones are the ones that are helping us with color. There are some people who are colorblind, aren't there? And there are more males colorblind than females. What does that tell you? It's what you said? So it is in the 23rd pair of chromosomes on the X chromosome. That's exactly right. So it's more males than females. But females can also be colorblind. Oh, here's that color light spectrum I was saying. So can everybody see a number inside of this? Can everybody see a number in this room? Some women are colorblind too. And I actually have a little colorblind book somewhere where you can do other different types. It's not just red green. There's other types of colorblindness. But some people, and I've had a couple of guys that have been in class that 1 in 8 men are colorblind. That's pretty common, isn't it? 1 in 8 if you think about it. That they can't see that number at all in there. Okay, so it's 16. All right, so okay. How do y'all feel about sight? These are showing you like how tiny those little bones are. I just had some pictures and some other things. If y'all can look these up. Look at so I'm trying to think of the number 1 cause of blindness in the world today, in the world, not in the United States, which is only 5% of the world's population, but in the world today is what? No, that's in the United States, of elderly. The number 1 cause of blindness in the world today. The reason, and this is in the world, and the reason that 50 years ago, there was a home for the blind in every small town. Y'all have heard of homes for the blind, right? And every small town is because of what's still the number 1 cause of blindness in the world today is chlamydia. Chlamydia. And that blindness happens at birth because the child moved through the birth and became infected with chlamydia, and it can cause blindness. So, and it does. It's still the leading cause of blindness in the world today. Another leading cause still is Neisseria gonorrhea. So it causes what? That bacteria causes gonorrhea. So this is in this country. How have we decreased those numbers enough that we don't have to have a home for the blind up in Peaceville or in any of the small towns anymore? So in any birth that happens in a medical facility or clinic, the infant will get a drop on each eye of erythromycin. And that erythromycin, just doing that has prevented so many babies from that. Erythromycin covers chlamydia and gonorrhea. Do all mothers, are they symptomatic if they have chlamydia or gonorrhea? Most are not symptomatic.
Do C-sections prevent that?
C-sections can prevent that, but C-sections cause way more other problems. So you wouldn't do a C-section. You know what you would do? You would just the drops in the eyes, and the drops in the eyes of the baby. I've seen parents who get upset about that because they say that they're in a monogamous relationship and they don't have any of that. So, but parents aren't even given. They're not given a chance to decline that. They can decline other things for their infants, but not that, because you're talking about blindness for that person the rest of their life, and it is still leading cause of blindness in the world.
So, I mean, erythromycin's not that expensive. Why not ship it off to other world or other
Well, they
countries?
do. We do.
Oh, okay. I thought you meant like-
We do, but it's still even with that, we still do have that. Well, you have some religious things too that won't allow those kinds of treatments. Like Mother Teresa wouldn't allow any kind of treatments or contraception or anything. Y'all knew that.
Well, I knew about the oral contraceptives, but I didn't know about the antibiotics, the drops on the eyes.
Yeah.
I mean,
So I mean, there's many people who wouldn't want, who just that is against their whatever to do. So that's why it's still. But anyway.
Now, when I was pregnant, they right away, first trimester, they did a STD test. They just said it was routine, just to make sure.
It is. It actually, and it is because there's some things that can cross the placenta and harm the fetus. So they typically do a screening. But you could also encounter something, you're still having sex up until, right? Was I the only one?
No.
I was joking when I said that. Not really, I mean, it's sort of true, but anyway, okay, over it. Look, so I'm just saying, that's why that old wives' tale about, if you want to go into labor, what are you supposed to do? Yeah, you have sex. That's right. Because in seminal fluid and semen, there's prostaglandins that can start contractions. Yeah, you'll do anything.
Yeah, that's for something at that point.
If you're 2 weeks over here, you'll do anything.
Right?
But so they can catch that early on. That's what I'm trying to say. So can they catch that early on?
Well, they can catch it early on, but you could be reinfected. You could be reinfected. And so what ends up happening is when you do hear people say that you don't need to do that because we're monogamous, you don't know if that person's been monogamous, that father's been monogamous. You don't even know if the mother's telling you the truth. You know what you do? You put a drop in your child. And it's just a drop of erythromycin.
Some doctors actually don't do the cervix checking anymore because it's they've come to find out that it can do more harm than good. Like if you, in the first trimester, it used to be they would do a whole check.
Yeah.
But it can actually rupture or something.
Oh,
They
well,
try not to
that
stick
would
anything in
be,
there now.
you would have to really worry about the person doing that procedure if that was the case.
What do you mean by cervical check?
Yeah,
like a screening, almost like a pat.
Oh,
Yeah,
yeah, I
yes.
remember. Yeah, my doctor did it.
Yeah.
My first one, my second one, they said they didn't want to because anytime you brush the cervix, you can mess something up.
Yeah, I've heard that. Up until
I think that you also, it probably just depends on the practice and, what they have found out is something they need to do or not need to do, So the thing is, and sometimes you get to go more comfortable with some things just because you know people. But anyway, the eye drops are going to happen if they're if babies are born in clinical facilities. That's going to happen. So y'all, we're finished. Do you want to pat yourselves on the back? Yeah. So, okay. So we're going to do some dissections. We're going to look at specimens of the brain. We're going to do some other stuff. I need a break. I'm going to go get those lists for you of the structures. I'm going to get those for you. Can I have 15 minutes, please?
Yes.
Thank you.
For